Yes, and here we are again,
Oh,
Dr.
yeah.
Hassan, and we're gonna talk about this time EMR ESD.
Yep, we will. And first we'll go with the EMR and then ESD. Here, just quickly again, I mentioned in the previous video as well, the scope needs to be really comfortable in neutral position. For whatever endoscopy you do, you need to be comfortable. Scope needs to be comfortable. Patient needs to be comfortable. So if any
The
of those is
physician has to be comfortable, right?
yes, exactly. That's very, very important. And other thing is like when there are loops in the scope, you can't really do the therapy, the fine therapy, because what happens is whatever you are doing here is not equally being transmitted to the end of the scope. So if there's a loop in there, if you're short in height, you can step back away from the patient. That straightens the scope. So anything I'm doing like this with this hand, with my wrist or shoulder needs to be transmitted equally towards the end of the scope. And with the other thing is your scope basically should be controlled with your left hand. Right hand is an accessory to advance the scope, pull the scope back, and use your needle, snare, your knife, whatever accessory is, and also to advance and pull the scope. So this is what we're going to do. We have EMR and ESD. EMR, obviously we start with the injection, but you can do underwater EMR, and that can be without injection. You can do a cold snare EMR without injection, but here we will demonstrate only
Yes.
with the injection and
Just
the hot
hard on the
EMR.
pig stomach to do, might be hard to do the cold water.
It will be. And it's just like a pig stomach. First of all, it's just a tissue explant. It's not a
Vascular,
vascular
yeah,
at all.
yeah.
So one thing is for sure, there won't be no bleeding. If there is a bleeding, that's a problem. Okay.
That's for sure. But do you have a preferred technique for EMR?
So
Or it depends?
It really depends on the type of the lesion, but either it's going to be cold snare or hot snare. I usually don't do much underwater, and as in my presentation I mentioned, biopsy forceps really should not be used for polyp resection. Only polyp which is 3 millimeter or 4 millimeter, you can resect that with biopsy forceps. Anything larger than that, 1/3 of the patients who will leave some polyp tissue behind, so should not be basically used. Cold snare EMR only should use a dedicated cold snare. I usually say is like if you're using a hot snare for cold EMR, does not matter how much you go to the gym, how muscular you are, you cannot resect really more than one tissue with a hot snare using it as a cold. So use a dedicated cold snare for that purpose. So here we'll just start with the one area, and you see the needle again. I mentioned previously too. For EMR, gotta know your scope. EGD and colonoscope. These two are different mechanics. Colonoscope working channel at 5 o'clock. EGD working channel at 7 o'clock. Colonoscope, big wheel away from you, gives you a really good apposition to the floor, and for that reason the teaching always have been to put the lesion at 6 o'clock position. There is a reason behind that. And for EGD scope, it gives you the best apposition to the top. So my advice, usually my principle is, if I'm using an EGD scope, my lesion needs to be from 9 to 3 o'clock. If I'm using a colonoscope, it needs to be from 3 to 9 o'clock. So that would be the best position for those resection of those polyps. If it's a upper in the duodenum, always use a colonoscope, and obviously cap on that. The reason for that is duodenal one, especially at duodenal apex, second part of the duodenum, your scope tends to fall back. So if you have a colonoscope, you just go on the greater curvature, rest your scope in a long position, and just sit there. You don't have to, it's not an unstable position. So I If my staff knows, if I'm doing a duodenal EMR, we're going to start with the pediatric colonoscope. So that just keep that in mind. Second, other thing about EMR, it's a duodenal EMR I'm talking about, and if you feel like it's really in tough location, tough position to begin with, put the patient on their belly. It will make it completely opposite of what you were feeling before. And it becomes much easier, position changes, and everything becomes totally controllable, basically. So here, needle.
What a beautiful tips.
Yeah, so here, needle is there, and I'm gonna ask terminology, we were talking about that earlier.
Because it's so important, because our nursing staff changes. We have some fluidity in every endoscopy unit. How do you treat your support staff and teach them what to do?
So sometimes you have a different, different staff coming in.
Yeah.
Mostly it's the same staff. They know what you mean, what you're talking about. Let's suppose you have a new staff working with them, and
How
you get
do
a
you train
needle
them?
from them. If I tell them needle in or needle out, doesn't
In
like,
they don't
what does that
understand.
mean?
What is
Like
in, where, out, where?
Yeah, exactly. For everybody, needle in, out is different. What I say usually is needle into the patient, needle out of the patient.
That's very good.
So here we're going to have a needle into the patient, and then if I need it out, I'll say needle out of the patient. I usually, especially here in this case, when I start injecting, sometimes I just fill the needle with saline. So what that gives you is, it's a like thin fluid. It helps you find the submucosa and your head starch, whatever you want to use. We are pretty cheap in Florida. We don't use this expensive stuff. And we just use a head starch, get like a 500
but here
cc.
we're treating you to,
Okay.
yes.
You're spoiling me,
to the,
basically.
yeah,
Okay.
well, that's our goal.
So, and for the injection, what I would do is, like, as soon as my needle, some of you have been taught to stab the needle
And
and
come
then start
back.
injecting and start pulling back. My worry about that is you will start from the peritoneum sometime and
Yes.
coming back. So what I do is, I will have the needle touching the mucosa, and I'm gonna ask my nurse or tech to start injecting. You see, when it starts injecting, then I might move my needle in there. Fluid finds the submucosa, and you look at that. It just
Look at
went to
that.
So go ahead,
Beautiful.
inject, and stop there for a second. So if now I want to inject to the left side of the lesion, I will lean to the right. Go ahead and inject, and that will go to the left.
Oh, look how
If I'm gonna
beautiful
go
that
to the
is.
right of the lesion, I'll lean to the left. Go ahead. If I want to inject upwards, I will lean downwards. Okay, go ahead. If I want to inject downwards, I will lean upwards. Basically, with one puncture, you are able to inject 4 to 5 centimeters sometimes. Like, don't have to just keep poking in different places. But if you want to do a second injection, don't start here. Start at the edge, right where the injection is already. Now you don't have to start before, you can just go in.
Into the place that
Into
you
the place
already
have it.
found.
Yeah. So you are just stacking the injection
Right.
side by side. Go ahead and inject a bit more.
How much do you usually like to inject?
Enough to lift it up
Right.
visibly.
Okay.
Needle out of the patient. Okay. And that's good enough. We'll take that out.
That is beautiful.
Yeah. So this is like it was in one place and
Yes,
goes
one-
all around. This is called
Doesn't
the
look like a pin cushion.
yeah.
We want to avoid that.
We want to avoid that. Exactly. We don't want a mucosal injection. We want a submucosal injection. Go ahead and smear. No, it's smear. Which one do we have? Any smear is fine. Yeah. Okay. It's a heart, right? Okay. So my go-to smear for any EMR is 15 millimeter round smear. And sometimes I use 10 millimeter as well. No, this is fine. Yeah, they told me it was 10. So go ahead and close. But mostly it's 15. 10 is good for the fibrotic areas where I have to use suction to resect that. And I will just quickly demonstrate on that too in a second. How much time do you have for
You
EMR?
have all the time in the world.
Okay. Good. So go ahead and open the smear. So this
So
is
why 15?
so
Why is your preference for 15?
it's
What do you
a-
like?
10 is too small to grab enough tissue, especially if I'm using resecting a 4 centimeter, 5 centimeter polyp. If I
Right.
start with 10, it's going to take
A
quite a bit
lot
of
of
time.
time, yes.
20 grabs too much, and
Yes.
that may slip out. So 15 just
It's
is
just right.
perfect. It's
Just
just
right.
right.
Just
And
right.
this is also, you don't want to open the snare like that. If you look at the snare,
Yes.
yeah, see, good.
Perfect.
So yeah, those snare
come
will
together,
come
right?
together right there. And what you do is, then in this one, I'm putting this. If I put it here,
Yes.
I still am able to do it. But if I put it upside, what I was saying earlier,
Yes.
from 9 to 3 o'clock, especially in esophagus, its a stomach is a different, but it would give you really good
Good,
apposition.
yes, for sure. And count for the gravity. too.
Exactly. Yeah. And here, what we'll do is, we'll sit there. It's more like at 9 o'clock. So I will suction a little bit, and I will ask my tech to start closing slowly. It's
It's
very
a stomach.
thick.
Yeah,
It's
this
a
is
stomach.
the stomach.
It's gonna slip like that. So let's
Yes.
open again, and just a little bit less. Close a little bit more. Let's start right here.
Yeah.
Okay. And what I will do is, it still might slip, but I'm gonna
Yes.
see if I can dig in there, use my suction to grab that tissue and bring into my cap. You see that, how it's coming in
Yes.
the cap? Okay, start closing.
No, it's just
It just slipped. It's not
yeah,
gonna-
just
yeah.
But I
You
want
have
to
a
ask
bigger
you, but when you're grabbing the tissue, how tight do you want your assistant to close it?
All the way.
All the way, right?
All the way, like just like trying to cut through it. What that does is, that would use the minimum amount
Yes.
of heat. But you want to feel that from, unless your tech nurse is really, really experienced.
But do you
wanna
check yourself?
Sometimes, if it's a new tech.
Exactly.
But, my experienced one, I just ask them, is it good to go through or not? So they
Yes.
tell me if they feel comfortable, they feel good about that.
But if
or
you're not sure, you check yourself.
I check myself. It needs to be squishy.
Yes.
Second thing is, when you move back and forth, the whole wall shouldn't be moving like that. It should be
Preferably
that.
not.
Preferably not. Okay, let's try that. That 20 might grab in this. The reason is because it's really, really thick mucosa.
Well, it's a stomach, pig
And it's the
stomach,
pig stomach,
yes.
yeah, but
It's
we'll try.
designed for other things. Yes.
It's really good for ESD.
Yes. Well,
Open.
that's the next step.
Okay, open. Okay. And you see that? You gotta
Yes.
be able to work with the snare, lay it down like
Yes.
that, and
That-
from
that was
left
beautiful.
to right or right to left. Stop
Nice.
closing slowly. Stop closing slowly. Close. Still,
Yeah, it's
look at
gonna-
that.
it's
Oh my
gonna-
God.
that's all right.
Open. We'll see you one more time, and then if not, then
We
we'll
do
just do
ESD.
ESD. Of that.
Exactly.
Okay. Close it.
There we go.
So for ESD, always mark the area which you want to
Sure. Do you mark in the colon as well?
Not in colon, in
Right.
the stomach and esophagus. Colon, if you mark it, there's no harm or no problem with that. You can put the marks, and marks help you. Like you have to. We will do that over here. You connect the dots.
Yes.
Then you have marked it. Colon. The reason you don't have to mark it, because the normal mucosa, you can easily differentiate that from the abnormal mucosa polyp after you inject it. It gives you a clear demarcation
Isn't
there.
it, Dr. Fukami always says ESD is easy. All you have to do is to connect the dots.
Connect the dots.
Yeah.
Yep, exactly.
The easy part is
Easy
a little
part.
bit, a bit questionable, yes.
So in this one, if you're in a colon, you want to mark, or even in stomach, anywhere, you can mark with the closed knife.
Yes.
But here it's not going to work with the closed because, again, because of the stomach, pig stomach and dry stomach. And so you put a one mark there. In this one, I'm using a quag and tip of knife to really mark that. And you can do with the knife closed as well. Especially when there is a blood flow there, but here obviously no blood flow, so that's why I have to use the knife out. But if you look at here, I am keeping those marks in a way that even when I go close to those, I see 2 marks still. So that because I want to connect the dots there. So you see that both should be in
So
one
in
view.
your view, you keep 2 dots.
2
all
dots
the, all the
always. So
time.
if you are, because otherwise you may not know where the second dot is.
And then you lose your way.
You lose your way. And if you're experienced enough, then you know what you're doing. But mark it in a way that at least 2 are in your view. So right there, we
that's
mark
beautiful.
it. And what I'll do is, now we will go ahead and do the dissection. But for that, first we will do a circumferential incision in that. To go into the mucosa, I need to use a endocut, like a little bit pressure on there and then tap there on one time. Need to know the length of your knife because you can't have a 4 millimeter RB knife there and then you're tapping like that and you are outside the wall. So here this is 2 millimeter. So right now, if I look here, this is my area. I can go either to the right or to the left, but this is not, I'm not controlling that with my knife. The scope movement is going to be closed, is going to be controlled with the scope itself.
So
Other thing what I'm doing is, like if you look at that my knife
Yes.
itself, the needle or the knife actually I should say itself is 2 millimeter.
Yes.
But there is a white catheter right a ring before that. So if you notice that my ring stays in my view
at all times.
at all time. And go ahead and inject.
I think we're,
We're having a trouble again, I think.
yeah.
Okay, go ahead and inject. So, a knife back first. Knife
Oh,
back.
I think when the air becomes too much, it
Oh,
pushes us
maybe.
away.
Okay.
Yeah.
Inject now.
Okay.
Injecting, but I'm not sure whether it's trying.
Okay. Yeah. Okay.
So a lot of the times, when let's say someone a novice like me does an ESD, and we do a circumferential dissection, mucosal incision, we don't
Knife.
trim enough. And,
yes.
And could you talk a little bit more about it?
So what happens is, like, if you are not deep into
Right.
the submucosa, you're just staying close to the muscularis mucosa.
Yes.
And that's where it starts bleeding. And your knife tip needs to be below muscularis mucosa.
Right. And it's not.
Yeah, it's not. So
Yes.
that's why you don't see that
Blue.
yeah, blue, exactly, the submucosa itself. Okay. So I'm just controlling that with my scope movement, you see that? And going step by step, just one step at a time. You don't sit on your paddle and start dissecting, because otherwise you're not going to have a control of that. So here I'll do a little bit, see if I can get underneath there.
Underneath, just so we
Yeah,
can
it's
show.
just show the submucosa.
Yeah,
it's
but
just
always a little bit challenging with a big
this-
stomach.
Yeah, it's
But
also
we're
there.
getting a lot of. Oh yeah, here
Yeah,
we
right
see
there
it.
you see that, and it's. Let me just cut a bit more around.
Yes.
So, and you don't have to go from here to there. You can still from there. You can go to the left side as well.
So, do you? How important do you find? And that might be a silly question. Retraction as you work.
So traction device, they are always very helpful. But I will use only when I can't get underneath, and let me just take a look. Yeah, I cannot get underneath. I'm not able to really separate the get a space, like really not get into the plane. In that case, I would use it. Right now, I think we are okay. It's just
Yes.
let me see. It's just a very, very thick stomach.
Thick stomach. That's
and-
all right. The whole idea of that presentation is to show what to look for,
Yeah, exactly.
and how to approach things. And I think in the interest of time, we will wrap it up. Can you give us one pearl or something? Yeah, as soon as I let go. Something when you start or thinking about ESD, where do you think, what is the important approaches or what to look for and to prepare?
So when you're starting,
Yes.
you just don't start from the duodenum, don't start from the cecum, okay? You start from the rectum, start from the stomach, have the nice like a lesion to start with, and examine it really good, mark it really good, and make sure the equipment is working.
Yes.
And
Oh, don't worry, we'll edit it out. Nobody, that's the recording. We'll
yeah,
edit it out.
yeah, so it's just a.
Yes.
So these are the things, mainly right indication, and in the beginning when you start from the rectum. That's the best place. That's the extra peritoneal. Even if you cut the muscularis propria, you're going to be okay.